Stanford Conversations in Menopause and Healthy Aging, the podcast, a trusted science-backed resource in menopause and healthy aging. When it comes to your medical and health education, tune in and submit your questions to world-class leaders in medicine and research. Stay informed, stay empowered, because your health matters.
Hi there. Welcome back to Stanford Conversations in Menopause and Healthy Aging, the podcast about living well through perimenopause, menopause, and beyond. I'm your host, Dr. Karen Adams, board-certified lifestyle medicine and OB-GYN physician and director of the Stanford Program in Menopause and Healthy Aging. I'm back with part 2 of our 3-part series, The Menopause Journey. What you can expect as you go through perimenopause and menopause. I'm joined by my colleague and friend, Dr. Sharon Hung. Dr. Hung is an assistant clinical professor of internal medicine, and she's director of women's health in primary care and population health at Stanford Healthcare. Dr. Hung and I do a lot of teaching of providers, but in this series, we are teaching you, the women who are going through it, along with us, because we certainly are on the path with you. Today in part 2, we're discussing treatments for perimenopause and menopause. Welcome back, Dr. Hung.
Thank you. So honored to be here and to continue to learn from you. So a lot to talk about treatments. Let's jump right in, yeah?
Absolutely. Let's go for it.
Okay. And then before we delve into all the prescription options, I'll start with a question my patients ask me all the time, which is there any benefit to certain foods, supplements, special diets to reduce the symptoms that are experienced during perimenopause that we talked about in our last episode?
Right. So important because it is really essential to be thinking about our health habits during this time. It's often a real opportunity to assess that and to think, am I doing everything I can do that's health promoting, above and beyond any medication that I might take? What can I do to help myself get through this whole process? Really, we recommend a whole food plant-based diet in general, to the extent that you can. My lifestyle medicine training has taught me that everyone should leave my office with a nutrition prescription. And so the nutrition prescription is 50% of the plate is always fruits and vegetables. And a quarter of it is whole grains. So brown rice, whole wheat pasta, oatmeal, nothing white. So no white flour, no white pasta if you can help it. And then the other quarter of the plate is beans, peas, and legumes, which is where you get your protein from. Those are plant-based proteins. If people ate that way 100% of the time, they would be vegan. They would eat no animal products, no meat, no dairy, no eggs. And most people cannot do that. And really, most people don't want to do that. That's not appealing to them. And so I always talk to people about good enough. Like perfection will always trip you up. You can never be perfect. So maybe you're vegan light. Maybe you eat plant-based 2 days a week, something like that. And if you have to have your white pasta with fettuccine Alfredo cream sauce on it, enjoy it, have it, don't feel guilty about it. But then the next day, have that be your rice and bean and salad day. So you kind of just play around with it a little bit to the extent that you can. What we know about that kind of diet is it's very anti-inflammatory. And when we go through perimenopause and menopause and our estrogen levels decline, we get kind of a little bit of just internal bump in our inflammation because estrogen is anti-inflammatory. So when our estrogen levels are dropping, we get a little bit of a bump in our overall inflammation. And we don't like inflammation. It's not a good thing. It can lead to risk for chronic illness. So anything you can do to lower your inflammation is a good thing. And an anti-inflammatory diet is always going to be plant-based. So that's one thing I talk with people about. The other thing that's really interesting is there's a lot of data that's accruing about soy, particularly because soy is a phytoestrogen. And so it's kind of a plant-based estrogen, but it's very weak. But still, it does have that sort of phytoestrogen character to it. The data is mixed right now about the impact of soy in our diets and impact on hot flushes and other kinds of menopausal symptoms. There's not enough data really to recommend it. But primarily because the studies have been done with different forms of soy. So some are soy powder, some are half a cup of soybeans, some are tofu. So there's not enough consistency in the data to really be able to recommend anything in particular. But I think it's really interesting and might be something that eventually we do actually make a recommendation that people eat a certain amount of soy each day. Right now, we don't really have that, but it does seem to be promising. And we're looking at that and following that data.
Interesting. And I love that you say good enough because I feel like, especially during this time, pre-diabetes, hyperlipidemia, high cholesterol, weight gain are very common. And then women kind of torture themselves to eat really well. But we also want to encourage them to not only eat whole foods, but things that are sustainable changes for years and decades to come.
Oh my gosh. I want to have you back and I'm going to interview you about that because I know you're an expert in weight management and how to kind of structure our choices as we're in midlife and beyond to really help make sure our bones and our muscles are strong and that we're maintaining a healthy weight and that we're decreasing our risk for those chronic conditions. So you're absolutely right. We have a lot of control over it, but we also beat ourselves up if we just break down and have a piece of pizza, right? And
Yeah.
that kind of takes all the joy out of things, I think, if you do that. And our colleague, Marilee Apezzo, always says, perfect is boring. Nobody wants to hang out with perfect, right?
Yeah. I love that because I'm like, I tell patients just to pick your vices and just eat them in moderation, but we can't have no vices to be
Right.
happy and survive in life too, right? So,
Right. You have to have the occasional glass of champagne.
absolutely. And speaking of soy, which you mentioned earlier, I know that you said there's still mixed data, but I think a follow-up question patients would often have is there, do we still have concern that it might increase breast cancer risk?
Mm. Right. We're going to talk in part 3 all about what we know about how hormones in general impact health risks and health benefits. In terms of soy, I get that question a lot because people know it's like a plant-based estrogen. And what does that mean? Really, it's so minimal. If you think about your hormones as a bucket, it literally is a drop in the bucket, soy. So I know some breast cancer oncologists advise against it, but from my perspective as a hormone expert, I don't caution people to avoid soy if they're at high risk for breast cancer or even if they have breast cancer. I think it's such a minimal impact that, if they're vegetarian and they eat that as a plant-based protein source, I'm not going to advise people not to do that.
Yeah. And I think some of my patients that see the cancer survivorship clinic, they also don't necessarily recommend that they need to restrict soy.
Right, right. Oh, they don't recommend restricting it. That's good to know. Right. Because people come in and they do tell me that they've been advised to avoid it by some oncologists. And I think the messaging varies. But really, again, those of us who are hormone experts know that the impact is so minimal, even, beneficial. If it turns out to be beneficial, it's still going to be a pretty minimal impact and mostly beneficial for those mild symptoms, mild hot flushes. Soy isn't going to treat severe hot flushes. It's just too subtle of an impact for that.
Yeah. And I think eating it naturally is fine from what I've heard from the cancer survivorship program, but we don't know if people are taking, soy supplements or really highly processed soy. That might be a different story. And I think we're just not really clear about that.
Right. And, to your point about supplements, they're really, and we can talk more about this when we talk about bones, calcium, vitamin D, those are certainly important. But I never recommend that people take massive doses of turmeric or various types of supplements. In general, we recommend that people eat the rainbow, that they eat a whole lot of plants and fruits and vegetables and plant-based protein and calcium sources. And if you do that, you're going to get what you need. And there's always a risk of over treating, over imbibing, end up with super high levels of things that aren't always safe. So we're careful. We will have a session on supplements later on in this podcast series, and we'll talk about all things supplement. But in general, it's better to go with your diet.
Yes, I love that. A rainbow diet.
Right.
And so let's explore the hormone treatment options. I've learned from you that birth control is a great therapy option during perimenopause. Can you talk about how treatment options are different between perimenopausal versus postmenopausal patients?
Right. Perimenopause is its own thing. It's its own entity, its own animal. And postmenopause is a whole different set of discussions. But perimenopause, people in perimenopause need three things. They need contraception, maybe, because as long as you're still having periods, even if they're rare every couple of months or something, that means you're making an egg and you could get pregnant. So that needs to be a consideration. It's such a joy when people have gone through their final period and they're 12 months later and they don't have to worry about contraception. But up until that point, you need to think about that. So contraception is one need. Symptom management certainly is another goal. And then the third is cycle control. Because again, when you're postmenopausal and you're not bleeding anymore, not having periods, you don't have to have that managed. But one of the major issues in perimenopause is people's bleeding is unpredictable. And we don't want to give them anything that makes that worse. And sometimes low amounts of hormone will not help it or actually make it worse and make things a little bit less predictable. So our goal is to either get those periods back to being very regular or to take them away completely. And so there are certain treatments that we can do to get to either one of those outcomes, either get those periods back to being regular until you're to the point of 51 or 52, or suppress them completely. And so birth control pills are really a great option for perimenopause because they check all those boxes. You get cycle control, you get symptom management, and you get contraception. You will not get pregnant if you're on a birth control pill unless you forget your pills or something. So birth control pills are terrific for perimenopause because you get all of those treatment goals are met.
Those are all great points on why birth control can be an ideal option during this time. And just building on what you've said, I think there's this common misconception that we can't use birth control on older women. But if they aren't smoking, they haven't had a heart attack or stroke or blood clot, their blood pressures are well controlled, it can still be a very safe option, right?
Absolutely. Up until age 55.
Mm.
Age is not a contraindication to being on birth control pills as long as you're under age 55. We generally don't use them after age 55, but up until that point, absolutely, without any other contraindications, you can absolutely be on birth control pills. And the common contraindications are if people are smoking, or if they have migraine headaches with aura, or if they have uncontrolled high blood pressure. Some of those things. But those are very specific to birth control pills and not necessarily applying to hormone therapy after menopause.
Right. And I first learned about that from you, that some things that are contraindications for birth control are not necessarily contraindications to hormone therapy. And so a
Exactly.
lot of patients might not know that they still have those options once they go into menopause.
Right, that's exactly right. Because hormone therapy is 1/4 of the strength of the lowest birth control pill. People often don't know that either. They think hormone therapy is a lot more
Mhm.
hormone than a birth control pill. No, it's 1/4 of the strength of a birth control pill. And that's why you don't get cycle control or contraception. With hormone therapy, it's not enough hormone to give you those outcomes, but it manages symptoms very well.
Yeah. And are you prescribing the combined oral contraceptives continuously or cyclically?
Right. When you skip the placebo pills, the sugar pills at the end of the pack, and go right to the next pill pack, we can suppress your period completely. By doing that, takes your period away. A lot of people in their 20s take their pill that way because the only reason they built a period into the pill is so that people would know they weren't pregnant. And so there's no need to necessarily have a period when you're on the pill. So yeah, you can just skip those placebo pills, go right to the next pill pack. And usually within a few cycles, within 3 or 4 pill packs, you're not having any breakthrough bleeding or spotting anymore, and your periods have suppressed, and you go on your merry way. And so that's ideal. That's the way we like to do it, is continuously.
Yeah, and that is a very common myth. Even now, my young patients are like, what? I don't need to have a period to be healthy.
Right, exactly. And it's just there's nothing really building up to slough. And so that's an important point.
And then what about women who already have an IUD? What can we do then to manage their hot flashes if they're having them in the perimenopausal stage?
Right. An IUD is also a great way to manage perimenopause because you get contraception and you get cycle control. So when people have an IUD, we're talking the levonorgestrel containing IUD, the ones that have progesterone in them, you have about a 50-50 chance of losing your period altogether, just no matter what age you are. And then if you don't fall into that category, for everybody else, they still have periods, but they're short and light, like half a day or a day. Or you just kind of spot now and then. And most people feel like any one of those is better than having heavy periods, each month. And so an IUD alone will often give you the cycle management and the contraception. However, it doesn't typically treat symptoms, hot flushes, night sweats, things like that, because it doesn't circulate much hormone in your bloodstream. So in those situations, we often do add an estrogen of some type, a patch or a pill maybe, or a gel or something like that. Our go-to is a patch. And a patch and an IUD is a fabulous way to manage perimenopause.
Yeah, and before we delve further into hormone therapy, I should mention we now call it menopausal hormone therapy or HT, and no longer hormone replacement therapy or HRT.
Right. Just so that people are not confused about what we're talking about. That's exactly right. Hormone therapy.
And then if someone's on those continuous birth control pills, when would you switch them over to hormone therapy?
Right. So in general, we just do that on an age basis. So when someone reaches the average age of menopause, 51 or 52, then we just step them down to a true hormone therapy regimen, and that usually works just fine. If their periods start coming back with that, then we know they're probably still in the perimenopausal time frame, and then we maybe would go back to another year of the pill and try it again the following year. But usually around age 51 or 52 is the time that we try to make that switch to step down.
Wow. Okay. Interesting.
Mm.
And then once women are postmenopausal, some are on estrogen only, and then others are on estrogen plus progesterone. Can you elaborate on why that is?
Right. And that's important when we start talking about some of the studies and what we know about the different regimens. So hormone therapy can be of two flavors. One is estrogen alone, and those are for people who've had a hysterectomy. And the other is estrogen plus progesterone, some type of a progestin, and those are for people who still have a uterus. And the reason for that is that estrogen alone stimulates the lining of the uterus, and it can cause the endometrium, which is the uterine lining, to change, to thicken, to proliferate, and even to turn into precancer and cancer. So if someone has a uterus and they are on estrogen alone, we worry about their risk of endometrial cancer. And the progesterone that we add protects the uterus from that. So, and we'll talk more in the next part about the difference of risk and benefits with those two different regimens.
Yeah. And following up on that, what are the forms of progesterone that we use in hormone therapy?
Progesterone can come in a pill. It can come in an IUD, or it can come in a very specific kind of skin patch that contains both estrogen and progesterone in it. So we make a choice about those different delivery systems depending on what the patient's needs are.
And what formulation do you generally recommend to your patients?
Well, my favorite is an IUD because the IUD just really manages the irregular bleeding that can still sometimes be happening and when people are early in that transition time. And that's just so nice because breakthrough bleeding is such a pain in the neck. And so IUDs are beautiful for that method. And then you get the patch benefit as well. And frankly, most of the gynecologists I know who are postmenopausal have an IUD and a patch because that is just such a perfect regimen it just hits the sweet spot of all of the different treatment goals. So my favorite is an IUD. And my next favorite is the pill, the progesterone pill, because the side effect is drowsiness. It hits the sleep centers of the brain. And so if insomnia or sleep disturbance is an issue, then I may lean toward recommending oral progesterone to help with that particular symptom. And you can use it with an IUD if need be. So, there are ways to kind of get both of those benefits, but you really don't need both the pill and the IUD. One or the other is adequate.
Right, right. And what about the estrogens? What forms of estrogens are available for hormone therapy, and
Mhm.
what do you prefer and why?
Right. So estrogen can come in a pill form. It can come in a transdermal form, or it can come through injections. Injections are very rare. We almost never use them. We use them in very specific situations. I think of my 4,000 or 5,000 patients, I maybe have one or two on injections. We tend to lean toward what we call transdermal forms, which are the patch, the skin gel on the skin, or a ring in the vagina, because when you swallow an estrogen pill, it goes into the liver, and the liver responds by making clotting factors. So you get an increased risk of blood clots if you're swallowing an estrogen pill versus something that is delivered through the skin. So we always prefer a transdermal form over a pill, or certainly over an injection.
Right. So you mentioned about 50% might have breakthrough bleeding, and we'll talk about the adverse effects of hormone therapy in our next episode. But what are some other symptoms that you counsel women when you start hormone therapy on what side effects they might experience that are
Mhm.
normal?
Most of the time, they just feel better. Usually, I say, you are going to feel like yourself again because they do. And oh my goodness, is it not just like the ceiling opening up and the sun shining in? It's such a relief. So most of the time, people just feel better. They sleep better, their mood's better, their hot flushes are gone. Side effects, mostly breakthrough bleeding, occasionally a little breast tenderness. That's pretty rare, but
Mhm.
I don't worry about that. If that happens, it usually goes away pretty quickly.
Okay. And let's say you're starting someone on an estradiol patch and maybe some micronized progesterone orally since they're having some insomnia. What are your go to dosages?
Yeah, typically I do a 0.05 patch because that is the lowest dose that's been shown definitively to protect bones. So I do a 0.05 patch, skin patch, and then I do 100 milligrams of progesterone, and that they take at night because the side effect is drowsiness. It helps you sleep. And so you're brushing your teeth and you're getting ready to get in bed, you take your progesterone because that will give you a better night's sleep.
And then we've talked about the oral and the transdermal estrogens. What about the local estrogens? When do you use those?
Right. There's a real difference between local estrogen and systemic estrogen. So systemic estrogen means that whatever form you're doing, you're circulating estrogen in your bloodstream. And if I were to draw your blood, it would look like you were taking hormones because the hormones are circulating in your bloodstream. And we need that for the hot flush management, the mood, the sleep, the joint pain, all of the symptoms that people get with menopause. But local forms are very specific and very useful if the only symptom people are having is related to a thing called genitourinary syndrome of menopause. That is vaginal and bladder symptoms, and that can be treated with vaginal creams, estrogen creams, or tablets in the vagina, or a ring in the vagina.
Oh, but I mean for the topical estrogens, what formulation would be your preferred?
Oh, I especially, and we'll have a whole session about genitourinary syndrome of menopause. But I love the cream because it can be very targeted. Often symptoms are coming from the opening of the vagina, not up inside. And so when we're treating up inside the vagina, we may not be getting right at the area we want to get to. So the cream applied right to the opening of the vagina is super effective and targeted. So that's really my primary go-to.
Great. And I learned from you to just tell patients to toss the plunger and just apply, right?
Exactly. It comes with a plunger, but I just say a little blueberry-sized amount on your fingertip is going to do the trick.
And then lastly, many of my patients who are very, frustrated, confused, they're doing online research on their own and they come across bioidenticals.
Mm-hmm.
How do you address that conversation?
Yeah, that's important. Bioidentical means that your body recognizes it, means that it's similar, in fact, identical to what you made in your 20s and 30s, what your ovaries were making. So estradiol, which is what is in the patch, is bioidentical. Progesterone, which is what is in the pill, is bioidentical. Testosterone is bioidentical. So it doesn't mean compounded. Compounded hormones are a whole different thing. Bioidentical forms of hormones are available in FDA-approved versions, commercially prepared versions. And we prefer those because compounding a hormone does bring with it the risk of purity concerns or batch-to-batch consistency. We're never sure if we're giving you exactly what you got last month because it's compounded each time. And it doesn't come with any kind of FDA mandated package inserts or anything. So in general, we avoid compounded. But I prescribe bioidentical, you prescribe bioidentical. It doesn't mean compounded. It means something that your body recognizes.
Great. Thanks for clarifying that. And I'm just so grateful to have you as a resource to help us all navigate this confusing period of our lives.
It is so confusing, isn't it? And the perimenopause transition is the time that people are the most symptomatic and the most kind of bugged by everything. And I think it's important to say once you're through all that and you're in the postmenopausal years, it's much more smooth sailing. And so, you have that to look forward to if you're 44 and listening to this and thinking, this sounds tough.
All right, I'm going to hold you to that.
Right. Thanks so much again for chatting about this with me, Sharon. It's always super fun to do that. And I look forward to having you back for part 3.
Of course. Thank you.
And the next one is going to be, please join us because it's going to be very interesting. We're going to talk about the Women's Health Initiative. We're going to talk about some other studies that really inform what we know about the safety, the risks, the benefits about hormones and how that knowledge has evolved over the 20 years since that big study. So thanks for joining us on Stanford Conversations in Menopause and Healthy Aging, and join us for part 3 with my guest, Dr. Sharon Hung.
If you've enjoyed this episode of Stanford Conversations in Menopause and Healthy Aging, please take a moment to follow or subscribe to our podcast on your favorite platform and consider leaving us a rating or review. It's a simple, zero-cost way to support our work and help others discover the show. You can also stay connected with us on Instagram, YouTube, and other social media at Stanford Menopause. For additional resources, event notifications, and other updates, be sure to visit our website, menopause.stanford.edu, where you can also sign up for our program newsletter. Thank you for joining us, and most importantly, thank you for your interest in advancing the conversation around menopause and healthy aging.